Greetings, everyone. This is PARM 2223, Unit 11, and this is the lecture on shunts, cerebral shunts, and we'll talk about what exactly that means. So this is a shorter lecture in total slides, so I may or may not be able to get this done in one go. We'll see how this goes. All right. So a little joke here. We know that September is hydrocephalus month, and please hug somebody because shunts are a pain in the neck. And you think, well, what does that mean? Well, you're going to see a shunt from the brain passes through the neck. So that's going to make more sense in just a few minutes, this joke. I know it's pretty bad. Okay, so the main reason you see shunts is a condition called hydrocephalus, and hydrocephalus is one of the, it's a substantial, usually a birth defect. It refers to enlargement of the ventricles, and there's lots of reasons why this can happen, both as a defect and as a progression of a disease, so on and so forth. So basically, we know we produce a certain volume of cerebral spinal fluid every day, nonstop. But that cerebral spinal fluid has to go somewhere. And sometimes there are conditions that prohibit the proper drainage or elimination of cerebral spinal fluid from the brain into, elsewhere. And as a result, the cerebral spinal fluid doesn't stop. It keeps building up and building up. It accumulates. And that's where you get hydrocephalus, sometimes called water on the brain. The main cause of hydrocephalus is spinal bifida, which is one of the most common birth defects out there in various forms. How common is this? Well, an estimated 125,000 kids have shunt-dependent hydrocephalus. Not just hydrocephalus, but shunt-dependent hydrocephalus, with about 1 to 1.5% of the total pediatric population. You will encounter adults with shunts, but most time when we deal with complications, it seems to be pediatrics are dealing with. Now, shunts tend to be very effective, but cerebral spinal fluid shunt failures account for a substantial volume of pediatric hospital admissions, and they have a mortality rate of 1 to 2%. Now, we're talking about a subset of a subset, but we're talking about still that's a substantial volume. That's a substantial volume of children who die from shunt failure every year. This is, I'd have to actually pull the numbers, but this is in excess of those who die of firearms, and don't know about total trauma, but this is definitely a substantial cause of pediatric mortality. The way to knock that down is rapid recognition. So the reason why I bring that up is this is another one of those things that I was unaware of when I got out of paramedic school. And sure as not, especially with Vanderbilt being a pediatric hospital in our area, we encountered this a fair amount. So the question is, what's up with it? Well, I'm going to give you a little background. It's obviously a complex topic, and I'm not an expert, but I'm going to do what I can. It's a little pathophysiology. We know that we produce about 0.3 cc's per minute, or about 20 to 30 cc's an hour, half a quart a day of cerebral spinal fluid. That's quite a bit. Take up a quart jar and imagine half of that in your brain or in your skull. Now remember that the Monroe-Kelly theorem means that the skull is a enclosed capsule and there's only so much volume. So if you increase the volume of fluid, you have to decrease the volume that's taken up by brain matter. This is the same as very much with increased intracranial hemorrhage. So most CSF is produced in the choroid plexus, which is in the ventricles inside the brain, and it circulates and eventually dissipates through the subarachnoid space into the spinal cord, and then is absorbed and distributed throughout the rest of the body. Usually, for most patients, this goes off without a hitch. So again, we talk about the Monroe-Kelly hypothesis. Here we have the skull. It's intact, hopefully. The subarachnoid space, which isn't just around the brain, it also goes into the ventricles, as you see illustrated there. You have the brain matter itself, what we call the venous sinus. And the reason we talk about the venous sinus is that's usually where, not always, but usually where the shunt originates. So we talk about hydrocephalus. It's an imbalance between production and absorption of CSF. As I talked about, the most common cause is spinal bifida. And when they do have spinal bifida, hydrocephalus is always the result of inadequate absorption, because spinal bifida results in a blockage within the ventricles and the subarachnoid space. Now, it's not all or none. Sometimes it might be just relative. They can drain some cerebrospinal fluid, but not enough to keep up with production, stuff of that nature. So really, it's the difference between having a normal day in the tub and drowning from accumulation of cerebrospinal fluid on your brain, which in turn causes severely increased intracranial pressure. We already talked about that. So let's talk about some of the clues that you might have that a child has not only hydrocephalus, but a malfunctioning shunt. And if it's a very small kid, and really not even a very small kid, in some severe cases, you might have bulging fontanelles, fluid leaking out through the sutures of the skull if the fontanelles aren't fully fused. That's if you're lucky. A kid with severe hydrocephalus, the fontanelles may never fully close because they're constantly being distended. Now, in the most severe cases in developing countries, you might have something like this, which is obviously horrendous for this child, I would imagine. But in most Western developed countries, usually things don't get to this level of severity. So we talk about cerebrospinal fluid shunts. What they basically do is they allow a pathway. That's what a shunt is a pathway or a drain from the ventricular system of the brain to another site in the human body. Now, this is usually the abdomen, which leads us to why a lot of these are called VP shunts, ventricle peritoneal shunts. So as you can see in that image there, the shunt drains. It drains from the brain and empties out into the abdominal space, where it's just absorbed through normal metabolic processes. Is not a big deal. There are some other really weird locations, including into the lumbar space, into the pleural space around the lungs, around the gallbladder, and even into the myocardium, which kind of blows my mind. But all those, if the peritoneum is not an option, all the ones I personally have seen have always been VP shunts, but certainly could be elsewhere. So when you look at the shunt, you have the catheter, the proximal catheter that goes into the ventricular space. You will have a valve, and these valves can be quite complex, but they prevent backflow. They also allow a point of access. And even in some cases, they can be adjusted to allow certain levels of flow without allowing too much flow. And then you'll have the distal catheter, which goes to wherever the site of absorption is, again, usually in the peritoneal space. So we talk about the valves, all sorts of valves, one-way valves, valves with a pre-chamber. Some of these valves will have a space that very similar to remember we went over ports in our ventricular access, where you can access them and drain fluid off for not us, I should say, where a physician could drain fluid off for assessment, very much like a lumbar puncture, a spinal tap, just without actually entering into this spinal space, which is obviously a lot safer. So lots of different variations on the pump and the pump mechanism. These are often spraying or various other analog methods of control. You see they can be accessed. And so this kind of illustrates the way that they are placed. And so it will actually go through, be palpable. This seems really weird, but you can actually palpate most of the shunt as underneath the skin of the skull, or underneath the skin, between the skin and the skull, all the way down through the neck, and then of course it'll disappear in the thoracic abdominal cavity. You won't be able to palpate it there. So what this means is, as part of your assessment, you can trace this, and you can feel if it's kinked, if it's got a leak, a bulge, and you'll feel like a hematoma. I mean, you won't be vigorous with your assessment, but it should be easily assessed and sturdy enough for standard palpation. And that can be part of your assessment. Here's a little bit better illustration here. Here's an example of the size of these shunts before as they leave the skull. Shunts can be, you can hook, or not you, but during a transport you may find a case where intracranial pressure monitoring is actually set up off the shunt. And there you'll see it's measured in centimeters of water. Now here's the thing when you keep this in mind, is these pressure monitors are precisely positioned next to the patient themselves. So if you were to adjust the patient's head, you would change the accuracy of the pressure setting. Does that make sense? I hope it does. So let's look at some of the problems we have with shunts. And one of the problems is over-siphoning. So the basic idea, and usually this doesn't happen very often because of the one-way valves, is that, but the idea is that if the patient was sitting upright, is that you would have an over drainage of fluid out of the cerebral vault, and obviously needs cerebrospinal fluid for the brain to be lubed, for it to get nutrients, for it to survive. So over drainage is a consideration. Now the good news is that in theory, if the valves are working correctly, that should not happen. Now you probably would never completely drain all the cerebrospinal fluid off, but it could certainly in theory drain until you have to the point where you'd have complications. Most of the over drainage is usually manifested as headaches. Now the problem is, of course, overaccumulation of cerebrospinal fluid presents as headaches. So this can actually promote a subdural hematoma, can cause deformity or of the brain, very, very similar to what you might see with shift of the midline, all sorts of problems. You can also have under drainage where you have excess in fluid, and here you can see shift and accumulation of severe fluid in this CT scan. So these valves, siphon control devices, are intended to prevent this from happening. They are palpatable, they are adjustable sometimes, not by us in the field, but you would palpate and feel where these valves are and notice if there's any leakage or anything around them. Or infection, I should say, also. So what you may see is hematomas, abscesses, stuff like that, all of which can distort or cause malfunctions of the valve. There are even programmable valves where this is not electronic, it's still analog, but through magnets you can adjust the pressure settings, the amount of fluid that's let through, and so on and so forth. And there you see an example of that being done and the device. And it's an outpatient process that basically you change the setting of the valve through magnets. And it's pretty simple. Is that it actually, and they can adjust for different patient positions, postural positions. And there's another example of one. I had several examples in here. And where it can be adjusted, you can see the stainless steel or titanium, probably not titanium, stainless steel valve. You can see the magnet there, and it changes position, and life is grand. So why doesn't everybody have a programmable valve? Well, the nutshell is they cost a lot more. The other thing is that because they're ferrous, you can't get MRIs with them. Because as you may know, that MRIs, magnetic resonance imaging, you can't have anything magnetic in there or else it'll just be ripped straight out of the patient. And I'm not exaggerating, these magnets can be very powerful. And there's no clear benefit over non-programmable shunts. There's been, back and forth. And they're increased in their complexity, which means increased chance of malfunctioning. So, Now, there's something called double arm shunts. Now, sometimes when a patient that they'll have appropriate drainage from one half or one part of the brain and inappropriate drainage from the other, or disproportionate. So you'll have better drainage from one side or the other, or worse drainage from one side or the other, but they'll need a shunt. So they'll have shunts on both sides, but with different valves on them to accommodate that. Any deterioration of a patient with a shunt, neurological deterioration, I should say, to include seizures, headaches. Headaches is one of the big ones. Okay, so as I talked about, headaches is probably, the way I think about this is your encephalopathic symptoms. So these are the same symptoms you'll see with the hypertension associated with eclampsia. These are the same symptoms you'll see with the hypertension associated with autonomic dysreflexia. Same things you'll see with the effects associated with hypertensive crisis. These encephalopathic presentations, they're the same, just the etiology is different. So headaches, seizures, behavior and irritability, what may be attributed to just psychogenic problems, changes in swallowing, vocal cord. So what you're basically seeing there is you're seeing dysphagia, unsteady gait, bedwetting, so on and so forth. Abdominal complaints, even if you have displacement of the catheter against the peritoneal wall, stuff of that nature. So what type of malfunctions? Well, the tube can break. That can happen, especially if they take a blow in the head. They're playing sports. It can become disconnected. Now, sometimes it's surgical error. Sometimes it's actually as the patient grows, what you will see is that they will, what was normally an appropriate length to the catheter or probing placement, it will displace. And that's also migration. Obstruction is the most common. So usually, remember, cerebral spinal fluid, you may have particulates, you may have infection that can actually clog up, even blood that can clog up the shunt and the valve. Infectious, meningitis, so on and so forth. Most of your infections are within the first 4 to 5 months of placement, and that's something you should consider. A kid has sudden onset of fever, and suddenly, within this 5-6 months of placing a shunt, they have sudden onset of fever, and they have the encephalopathic symptoms. It may be perioperative infection. Matter of fact, you hope it is, because the other more common cause is meningitis, and that's bad news for everybody. And of course, over drainage as well as under drainage. So, what are we looking for? Well, if you see bulging fontanelles, fluid collection along the shunt, so sometimes there'll be leakage around where the spike, I shouldn't call it a spike, but where the valve exits the skull and then snakes around the skull itself. You will have fluid leakage that will migrate and follow the path of the tube. If you see that, that's very indicative of under drainage. Of course, ultramental status and so on and so forth. Things that suggest infectious stuff is, of course, fever. That's the purulent drainage is the infectious drainage. You get erosions. You get, you just have to visualize the actual sites and trace the shunt down. Abdominal perforation is rare but serious, and what you end up seeing is a peritonitis resulting of this. You may see some ascites and congestive heart failure, but that's probably pretty. That's going to be pretty obvious at something, especially in a young kid. You can have a hernia develop that then can cause perforation and encapsulation, and there's a term for the hernia when it gets twisted. That's just escaping me. Also related to this. So, here's some things to ask and some things to talk to your patient about, or their parents or a caregiver. Have they had shunt malfunctions before? If they did, is this similar to that? Have they had any recent blows or trauma to the head? Any other issues? The younger they are, the more likely they are to have shunt failures. Obviously, the older they are, as they become more stable in their growth and their anatomical changes that decreases a bit. And keep in mind that while a patient may have a shunt, of course, doesn't mean that that's the cause of their altered mental status or other problems. So, like all these technology or special needs, I probably shouldn't use special needs, but all these people with issues, involve them in the care plan. Involve them in what they have going on. Involve them and ask your history and so on and so forth. In addition to recognition, find out where they normally get their care. Unless the patient is unstable or has rapid deterioration, these patients will be shunted to if they're a kid, a pediatric hospital or a specialty hospital. So make sure that they go to those type of facilities if you have those options, if you have choices. Cardiac monitoring is appropriate, and I think, well, why? This is predominantly a brain issue. But remember, herniation syndrome from Cushing's triad, need to monitor the heart for that. So, with that in mind, I hope this wasn't too painful, and I hope this was informative, and I'll see you out there.